All right, good morning, everyone. Welcome to the Rural Community Action Assembly on Healthcare Workforce Pipelines, Apprenticeships, and Community Health Worker Models. My name is Nathaniel Borick, and I am an Outreach and Administrative Associate with the Federal Reserve Bank of Philadelphia's Community Development and Regional Outreach Department. Thank you all for joining us. And on the next slide, I'd like to say a special thanks to our partners, Penn State Center for Economic and Community Development and the Center for Rural Pennsylvania. And then on the next slide, I'd also like to mention that our agenda, including biographies, the slides for today, including an agenda and biographies for the presenters, can be accessed through a link in the chat. We'll kick off today with opening remarks, which will be followed by the panel. After a 5-minute break, we'll then go into small breakout group discussions, and then we'll reconvene as a whole so that everyone can report back on what their small breakout groups discussed. And then lastly, we'll have an optional networking lunch. On 2 slides ahead, as a disclaimer, today's assembly, except for the breakout discussions, will be recorded. Additionally, the information, analyses, and conclusions set forth are those of presenters and do not necessarily reflect the views of the Federal Reserve Bank of Philadelphia or the Federal Reserve System. Please log in today with the email address you used to register and enter your name and organization in Zoom so that we can correctly assign you to the breakout groups. If possible, please enable your camera and be prepared to ask questions to our panelists and discuss your feedback with other attendees. Remember to mute yourself when you're not speaking. And please remember to take the evaluation survey after the event. We value your feedback and use it to inform our programming and research. Now that we've covered these guidelines, I am thrilled to introduce Stephen Johnson, president of UPMC Susquehanna. Steve has served in his current role since 2016, but has been a leader in the healthcare sector in North Central Pennsylvania and the broader region for many years. You can find his full biography in the slides linked in the chat. Steve, thank you so much for joining us today.
Well, thank you very much, Nathaniel. I'm delighted to be here, and I look forward to participating in the conversation as the morning proceeds. Let me begin with a quick reference to a Robert Frost poem. 2 roads diverged in a yellow wood, and I took the one less traveled. Many of you will recognize this poem by Robert Frost. It's often quoted by high school graduation speakers, and we are obviously in that graduation season. During this time, administrators and students alike will be reflecting on one of the most unusual 18 months, certainly in their history, arguably in several generations' history. As I reflected on a college graduation I attended last week, I could not help but reflect on the unique challenges of rural life and noted the age-old question of where to work and what to do is now more complicated for these young people than ever. So the purpose of my comments this morning are to highlight that out of unique complexities and challenges of rural life, we can discover unique simplicities and solutions. And that partnership, not partisanship, should be our guide. I'll begin with some background on rural communities' experience, then highlight 3 areas on which to focus our unique solutions. In terms of background, many rural communities like those in North Central Pennsylvania continue to deal with population decline. On average, rural citizens, for example, are older, have higher mortality rates than their urban counterparts, have lower birth rates, are often weathering the loss of industry and services, and dealing with the corporatization of Pennsylvania's #1 industry, particularly important in our rural areas, and that is farming. And they often have an inherent distrust of government. The result is that rural areas tend to export their young people for job opportunities and for social life. In my industry, healthcare, we are currently suffering from national shortages of more than 100,000 physicians and more than 1 million nurses and an untold number of emergency medical technicians, radiologists, phlebotomists, and laboratory analysis. These individuals, unfortunately, disproportionately locate, even when they are available, to urban and major suburban areas. Often these are places where they've attended school or where they've married and started families. They move there maybe because their perception there are fewer opportunities at home in their rural area. And so as they relocate, they tend to stay. And that contributes to the workforce decline as well as the overall outmigration of rural citizens. The COVID pandemic has also been an accelerant of this exodus, some for pandemic-related shutdowns, and they've lost their jobs or their jobs have been temporarily suspended. Others because they lost childcare or adult care. Many rural people take care of their adults, aging adults in place, and as well as children. So women have been particularly hit hard because they tend to be the predominant family caregivers in these rural areas. That affects healthcare in some respects disproportionately as well because we have so many women in our workforce. Some have left the workforce because their employers determined that now is a good time to automate. So we have this whole technology acceleration going on in the field, in particular of robotics and artificial intelligence. And finally, some of our most senior and most knowledgeable employees have chosen to retire because they had an experience with a healthcare scare of their own, or they lost a loved one during this time frame, or candidly, just because they can. The stock market has been good, and some senior members of our workforce have looked at this situation and said, now is a good time for me to retire. And as they leave, they take with them an extraordinary amount of organizational wisdom and intelligence. So what do we do about this? I'll suggest that there are 3 areas of opportunity, and that in each of these areas, it's important to develop solutions with people who live in and around these communities, because people will support what they help create. Those 3 areas include transportation and communication. I'll talk a little bit about education as a second area, and then also a short bit about immigration, I should say. So when I think about the issue of transportation and communication, the importance of keeping rural communities connected certainly comes to mind. And for Pennsylvania in particular, which has the highest number of road miles of any state in the US, and incidentally, and somewhat unfortunately, the highest number of deficient bridges of any state in the US, connectivity takes on a very physical meaning. Now, this is important, and we need to pay attention to maintaining roads and bridges. But the real infrastructure, transportation, and communication that I'm talking about is broadband. The ability for communities to connect on the internet across these rural areas is incredibly important and becomes more important every day as more and more parts of our society and of our information and industrialization centers move to broadband-based systems. These are critical for our communities. In many areas, there is no internet connection. And believe it or not, back in some of the hinterlands of our rural communities, there are still people who either have no cell phones at all because there's no service, or are using old flip phones and have no computer capability, again, because their local links will not handle the capacity necessary. We need elected officials, both Democrat and Republican. We need local, state, and federal workers, elected officials, all working together to assure that these investments are made in a timely and appropriate fashion. We need partnership, in other words, not partisanship, on this critical issue. The second issue I'll comment on briefly is the need for more practical education. We need to grow our own future generations. The reason I say that is because there basically are two groups of employees that we look at here in these rural communities. The first are those who will relocate for a job. They're the higher paying medical positions, for example, or engineers. For these, our focus is on recruiting and retaining. Those jobs where the pay scale does not support relocation, these we focus on training and retaining. And those by far are the great majority of those we employ. An example of recruiting and retaining is our family medicine residency training program. Lisa commented on that as we were gathering here this morning. Dr. John Bowl is leading the work to expand the family medicine residency training program to include a specific rural training track. Just again, to use this as an example, we've graduated a little over 300 physicians in the last 45 years that this program has been active. And of those 300 physicians, more than 200 remain in this region with their full-time practices and with their families, obviously having been located here as well. To that group, we're looking at adding an even larger number of educational slots with an even greater rural outreach potential. We would expect that program to be online in the next couple of years and to add further to this example of recruiting and retaining into our community. The other example I'll use has to do with training and retaining. And for that example, I would give you our partnership with the Pennsylvania College of Technology, an extraordinary technical institute located in Williamsport. 20% of our regional healthcare workforce has graduated from Pennsylvania College of Technology. To give you a rough idea, that's over 1,000 employees, many of whom are nurses, but we've also graduated, in addition to the RNs, we've graduated LPNs, paramedics, radiology and surgical technicians, hospitality staff, landscaping staff, and more. These are individuals who have completed clinical practical work at our hospitals and with our doctors and nurses in their outpatient clinics. It's a form, if you will, of apprenticeship program. It's an example also of where we've identified the need for certain skills or trades and worked with the Pennsylvania College of Technology to help educate their students and then hire them upon graduation. Heating, ventilation, and air conditioning, by the way, is another example, and I suspect we could share a number of specific experiences, but don't quite have the time to go into all that detail today. I would mention also, though, that the partnership has numerous components. One would be the clinical rotations that occur on our hospital campuses, but another one is an example in Wellsboro where we donated a building to the Pennsylvania College of Technology explicitly for the purpose of retrofitting so they could expand their LPN program. That program is now online in that location, and they've been able to double their number of LPN students from 18 to 40. We're the beneficiary, again, of most of those graduates, so that's been a very, very successful program. Another area we're working with the Pennsylvania College of Technology is in second career employment opportunities with a particular focus on military and citizen soldiers, if you will. Some great opportunities we think there that are only beginning to take shape now. As employers, our job in these rural regions are to anticipate the skills and capabilities that we need, and then to participate in designing and deploying the appropriate apprenticeship programs and practical experiences that these students need to be successful in our communities. The focus, though, from a cultural standpoint, needs to be on lifelong learning and building a culture of community commitment. That all is implied in the work that we do in these rural settings, but it's extremely important and should never be taken for granted. The bottom line is that while we continue to make ourselves more attractive to those willing and able to move into our communities, we must also invest in those who we can train and retain in our communities. The third and final area I'll comment on is thoughtful immigration. I would argue in many respects, this is the legacy of our nation's founders. We are a nation of immigrants. Appropriate immigration is necessary to help feed our employment needs. Our nation was built on that. I had a family vacation just 2 summers ago where I took my son and his wife and children to Ellis Island and the Statue of Liberty. And we were able to find boat manifests showing when some of our ancestors came to this country. They were Scotch-Irish and of German descent, and were the hand laborers for the first couple of generations that they were in this country. We need a continued focus on this kind of organized immigration, noting the extraordinary service that these individuals can provide. We need, as we conduct effective and appropriate immigration policies, we need respect and dignity. We need diversity and inclusion. We need to focus on their community and on our communities. Some examples in our area are migrant farm workers, immigrant staff working in the hospitality industry, and nurses for us from the Philippines that we've worked to help come to the United States and practice in our hospitals. For us in rural areas, this means we need to focus on proper social discourse around the right community connections rather than the often polarizing echo chamber of the internet. So in closing, I believe that hope precedes action and that heart precedes hope. And so I encourage you to feed your heart with those things that reflect commendable service, demonstrate compassionate commitment, and build community. And so I will end where I began. Just as World War II permanently affected our great-grandparents' generation, and the Twin Towers of New York impacted our parents' generation, COVID will forever be imprinted on this generation's psyche. Our memories will range from the social isolation and hoarding of toilet paper to FaceTime technology, Teams meetings, and virtual cocktail parties. But I also hope our memories will include the miracle of vaccine development and deployment, and the incredible resilience of people from all races, cultures, and physical constructs who've helped care for those suffering from this pandemic. When Franklin Roosevelt, our 32nd and only 3-term president, died in Warm Springs, Georgia in April of 1945, he was posing for a portrait and composing a speech for an upcoming Jefferson Jackson dinner. Today, I'll leave you with his last written words. The only limit to our realization of tomorrow is our doubts of today. Thank you and enjoy your session.
Thank you, Steve, so much for those very thoughtful remarks. That will really help to set the context for our panel and inform our breakout discussions later in the morning. We'll now turn to the panel. It is a pleasure to introduce Lisa Davis, the Director of the Office of the Pennsylvania Office of Rural Health. Lisa is recognized as a leader across the Commonwealth, regionally, and among her counterparts nationally. You can find her full biography and the slides linked in the chat. Lisa, thank you so much for moderating this important conversation.
Nathaniel, thank you so much. I really do want to commend the Philadelphia Fed for organizing this session. In my career in rural health, workforce has been and continues to be the predominant issue. And I so enjoyed and appreciated Steve's comments. And Steve, I hope you don't mind if at some point I use some of the words that you have said with proper attribution, of course, because I think that you really did highlight so many of the issues that workforce, regardless of geography, but especially in rural areas, has been facing over the last at least 30, if not longer, years. There have been a number of initiatives at the federal and state levels and also within communities to address workforce, and they have been tremendously effective, but we still have so many places to go. So just very quickly, because I am not the person who you want to be hearing from right now, is I'd just like to tell you just a few minutes about the Pennsylvania Office of Rural Health. Our mission is to enhance the health status of rural Pennsylvanians and to increase access to high quality healthcare services in rural areas. We are one of 50 state offices of rural health in the nation. Our program is funded at the federal level and was funded in the early 1990s so that there was a state office of rural health in every state that would be focused exclusively on the mission of increasing access to healthcare services and increasing the health status of rural residents. So our mission and our mandates are to be a source of coordination, technical assistance, networking, partnership development, recruitment and retention of healthcare providers. We have been very fortunate to work with many of you across the state, and I see so many individuals who are not only long-term colleagues, but close friends of the Office of Rural Health. Working with all of you is an honor for us every day, and to be able to stand here as the voice, the collective voice for rural health in Pennsylvania. So now what I'd like to do is to move to the panel, because we have three wonderful presentations that are going to reflect various components of the workforce delivery system. And I think that you'll very much enjoy listening to these individuals, several of whom I've known for a long time. So this is terrific. And again, I want to commend the Fed for talking about this. Workforce is a challenge, and it continues to be a challenge across the United States and here in Pennsylvania, especially in our rural communities. So our first speaker is Cerise Greenstein, and she is an assistant director for training and development at the Penn Center for Community Health Workers, where she works with healthcare and nonprofit leaders across the country, helping them to adapt and implement IMPACT, which is an evidence-based community health worker model developed and tested at Penn Medicine. So Cerise is going to be talking with us about the IMPACT model and about the important role that community health workers play in addressing community-based healthcare. So Cerise, it'll be delightful to hear from you, and thank you so much.
Thank you so much, Lisa. I'm delighted to be part of the conversation, especially appreciate being invited to this conversation coming from the big city. Such an important conversation we're having today. And I'm excited to share a little bit with you. Lisa did a little bit of my intro, but once again, my name is Cerise. I'm coming to you from Philadelphia. Thank you, Sean. I have control of the screen. Beautiful. I work at the Penn Center for Community Health Workers. We're a national center of excellence for community health worker research, patient care, and implementation. We developed a community health worker model, starting with talking to the folks in our community. We work in West and Southwest Philadelphia. We did 1,500 patient interviews. And that helped to inform the intervention we designed, which is a patient-centered a community health worker program that's patient-centered. We delivered the program and continue to deliver the program in Philadelphia, and we tested it in 3 clinical trials, and I'll talk a little bit about those results. But we saw some good things, and that has helped us to both grow the program internally. So we have a partnership at Penn Medicine. We have over 30 community health workers. We've served over 15,000 patients in Philadelphia. And over the last couple of years, we've started to work around the country with all kinds of partners in urban and rural areas at different like types of organizations and healthcare and nonprofit. We have 50 member organizations across 20 states. And it's my job to work with folks to help them to adapt our program, help use it in a way that's faithful to the model to help achieve similar results. The work is very exciting, and we are just in general, advocates for the community health worker workforce. So we've been working on policy initiatives and helping just to really elevate the workforce. So I'll talk a little bit about that as well. Okay, so we always start talking about community health workers because they're at the center of our work. And for us, it's really important to talk about who a community health worker is. I'm also going to talk about, what we think community health workers should do and why that's important. But we always start with who they are. So there are two key components to what we're looking for when we bring on community health workers to our team and how we help support our partners. First, community health workers share a common background with the people they serve. So that could be a neighborhood or a location where you live. It could be a racial or experience or like an experience with immigration. And it's that common background that provides, the beginnings of the bridge between the community health worker and the patients they work with. But there's this other component that's just as important. It's that community health workers are natural at their jobs. They were community health workers long before they got the job. They are great listeners, they're empathetic, and they are the people who help their neighbors when they are hungry, when they're sick. They're folks who give people rides. This is something that they spent their whole life doing. And we are lucky enough to find folks like this who have, this sort of dual combination of characteristics. And they're perfect at connecting with patients and helping them with their needs. But what we found from our work, from our research, is that the most effective community health worker programs allow community health workers to work in a really holistic way with patients. So they may be doing some healthcare navigation, advocacy, social support, any combination of the roles listed on the slide here. But the important thing is that it starts with that trust and that relationship between the community health worker and the patient, and that the community health worker really follows the patient wherever they want to go. So yeah, as I said, we have partners around the country. I have, and I think we can share in the chat, a link to one of our partners, who's a community health worker at Ballad Health, which is a rural health system in Tennessee, talking about her experience with being a community health worker. And you can see like this quote from her, and I encourage you to watch the link. Thank you so much, Nathan. For her, the job is a dream come true. And what she says in this video is it doesn't matter like how many degrees she could get or what types of other roles might be available to her. Being a community health worker really feeds her soul. And yeah, hearing her talk about her work really, will light anyone up. The story that she tells is of a patient she calls Serene. When Bree met Serene, she learned about who she was. She was referred through the hospital, but when she got talking to her, she asked her about who she was, what was important to her, and what was going on in her life. She learned that the patient, Serene, had been previously incarcerated, and her children were in the foster care system, and at the time she was homeless. And there was nothing Serene wanted more than to have her children back in her home. So Bree knew exactly where to go with the patient. She worked with Serene on like a detailed checklist about what she needed to get her children back in her home. She helped her find an apartment, and Bree is like a community leader. So she was connected to a women's group in her community, and that women's group helped to furnish the apartment quickly. Bree helped her get the appointments she needed, get drug tested with her parole officer, and by the time they were finished working together, Serene was back with her children. And yeah, in the story, she reports that Serene's now 1 year sober, and she still is in contact with Serene. And she, also started to work on some of the health needs that were the reasons that Bree was connected to her. So she started going to her primary care doctor and working on her health. So I encourage you to hear from Bree. And I'll kind of refer back to, kind of components of the story that show you a little bit how we approach community health worker work. So that story is, magic and helps us to really see the potential of community health worker programs. But in reality, a lot of community health worker programs have struggled, particularly in this country. And so before we launched into creating our program, we wanted to understand these pitfalls and understand what wasn't working. So we looked at the published literature, and we talked to folks in the field, and we identified some key challenges of community health worker programs. And I'm going to review them quickly. The first one is staff turnover. The literature showed up to 70% turnover in just a year in community health worker programs, which of course makes it extremely challenging to support patients in a consistent way. But of course, if we're here because we're thinking about retaining people in our workforce. We think that some of this has to do with the lack of infrastructure in community health worker programs. There might have been, in some cases, an approach where it's let's get this awesome person and hope they can help our patients, but not provide them with the really structured support that can help that work be successful. We've also seen in the past a lot of disease-centric community health worker programs. You have a diabetes CHW, an HIV CHW. And, there were a lot of challenges with that model. I mean, one, that's on here is it didn't necessarily show the outcomes desired. And what we saw is then the work became extremely clinical, and community health workers are not clinical, right? They don't come with the certifications or they're the clinical training. They come because of those qualities and their ability to connect with people. So the disease-centric approach and that clinical focus just, really is for the most part not particularly effective. Another challenge that a lot of programs struggled with is the balance between community and clinic time. So are community health workers clinic workers? Are they, at a desk, or are they kind of out in the community? And for us, the answer is both, but there have been challenges in sort of maintaining that balance and providing, again, a consistent presence in the clinic and in the community. And then overall, there was not a lot of evidence that community health worker programs were achieving the desired outcomes that people were looking for. So we designed a program around these challenges. First and foremost, we want to make sure to get the right people in the job. That helps them stay in the job, because if the work fits them and they have the support they need, they will stay. So we have some hiring strategies that we've employed over the last 10 years that have gotten us to a 2% turnover rate at our organization, which we're very proud of. And I'll talk a little bit about other strategies that we use to retain our community health workers. We have developed easy to use work practice manuals that walk folks kind of step by step through how to work with patients and where to go if you need support. And that has helped to provide a clear infrastructure for team members, not just community health workers, but the folks on the team that support them, like their managers and other team members. And at the center of everything, we've designed a patient-centered program that focuses on social root causes. So again, thinking back to Bree, we didn't really hear in that story about the patient's medical conditions, and Bree did hear some of that, but the focus there, it was really on whatever the patient needed. And it was really, at the time, it was about stabilizing her housing. It was about getting her children back. And that is really the model for the program. And what we've seen is that translates into outcomes related to the health goal that brought the patient to the community health worker's door. And then we have some strategies for balancing community and clinic time that we found effective. And, and we've helped folks adapt in rural areas where the travel time is slightly different. And doing some sort of operational planning on how to allow community health workers the time and space to be at the hospital, to be at the clinic, and then to make those journeys to patients' homes where the work of addressing the social determinants of health really happens. And then we conducted our randomized control trials. I'll talk about those in a little bit. But the overall structure, I guess, again, you heard, in the story with Bree, community health workers meet patients, maybe in the hospital, maybe in their homes. They get to know who they are, what's important to them, and set goals related to what the patient wants to accomplish. They support patients for a defined duration of time, which helps to set clear boundaries with the patient and helps community health workers to maintain steady caseload. So again, their job is predictable. They have a steady amount of work, and they can, give the patients the type of support they need. And then any community health worker, as they're working with a patient, should be looking for ways to connect the patient to long-term support, whether that's a support group, whether that's a family member, or some other kind of case management or social service that's going to support those gains that the community health worker made with the patient during the time that we're working together. So using that model, this is a little bit of what our research shows. Again, I have a link to a pooled analysis of all 3 clinical trials, but across the clinical trials, we saw some amazing outcomes. So patients who work with an impact community health worker see improvements in their chronic disease control, improvements in their mental health, improved access to primary care, and in one clinical trial, we saw a 65% reduction in hospital days. So it's that last metric and some of those quality metrics that helped us to show a return on investment for our system. And one of the things I do is work with folks around the country to show, based on their financial incentives, how investing in a community health worker program not only improves people's lives, provides stable jobs, but there's like a real business case for it. Again, there's a link to this that I think is in the chat. Thank you. Yes, randomized control trial. Thank you for that. So that was a lot about impact. Taking a step back, we are advocates for the community health workforce writ large. I have a link to this cool infographic. This is just kind of the top of it, but the high level here is community health workers are a part of our healthcare workforce. And they're growing, and we know there has been a lot of demands on the public health system this year. And there will be, sort of a growing role, hopefully, for community health workers in our public health and healthcare infrastructure. Oops. So a little bit about, the sort of like particular perspective of this conversation today, which is like how are community health workers part of a workforce development strategy? So one thing to highlight is, what I said at the beginning is we're looking for people who reflect their community and who are natural listeners, which means for the most part, it really doesn't matter what's on their resume, so we really try and get in front of people so we can connect with people who have those characteristics and then offer them, a stable job in healthcare that doesn't require their own credentialing or licensure. So we open doors for folks who, had been working in like possibly lower paid and less stable positions. And then, the other thing, the sort of, again, with the same stream with hiring strategies, if you're hiring people who reflect your community, then you start to build a workforce that reflects your community. And that is very powerful for a lot of organizations, and it's particularly important for us. We're based in West Philadelphia and have, being able to bring on folks from that community and also help them inform our organizational direction. So particularly in the last year, there have been a lot of opportunities for our community health workers to meet with our CEO and our leadership at the health system to inform the organization's direction in terms of making like a more just workplace and having a impact on the communities that we're in. Community health workers have lived experience with racial and social injustice, and so their perspective is extremely valuable. The other thing is, like I said, we've had folks on our team for up to 10 years, and one of the ways that we've been able to support and sustain our workforce is that we provide opportunities for advancement. So we have a structured career ladder where community health workers can advance within the patient care realm and also get experience in other domains. There are associated promotions and raises with those initiatives. So if you are interested in hearing more about our workforce, our career paths model, we have an article talking about how we developed it and what it looks like. We can share that in the chat. And then I'm just spending my time, which is perfect. So just a little bit about policy. So like I said, we are interested in being part of conversations, initiatives, and changes to help community health workers grow as a part of our workforce across the country. So one of the things we're working on with the National Center for Quality Assurance are national program standards for community health worker programs. So what this does is it establishes kind of a set of guidelines that would be tied to financing that would help ensure that when folks are hiring community health workers, they have the supports in place for community health workers to have good jobs and be able to like deliver high quality patient care. So really excited about that. There's a recent funding announcement from the CDC. I guess it's on the next slide, so I'll go to that. $332 million for public health departments to employ community health workers. And one thing we've seen over the last years, as I said, a lot of like, a workforce surge in the public health arena. And, we are excited about all the different roles that community health workers can and will play. So we've heard about community health workers helping with vaccine access and education. We have worked with community health workers who are actually also doing contact tracing, which has been a very cool program. And I'm excited to see kind of the other opportunities for community health workers to be part of our public health workforce. All right, that's it for me. Thanks for having me.
Cerise, thank you so very, very much. And I do want to let folks know that here in Pennsylvania, the Pennsylvania Certification Board has established certification guidelines for community health workers so that they can be not only certified, but integrated into healthcare delivery systems and health reimbursement models. So that is available on the Pennsylvania Certification Board website. So Cerise, thank you so very, very much for your presentation. And we might be running a wee little bit behind schedule. So we do have time for maybe one or two very quick questions. I've been monitoring the chat box. There are a lot of great resources that have been posted from Cerise's presentation. So feel free to access those. Micah, I saw that you had raised your hand. Did you want to ask a quick question?
No, I didn't raise my hand. That was applause.
Oh, that was applause. Okay, great. Yes. And we are trying to monitor those who raise their hand. You can either put your question in the chat box or raise your hand or unmute yourself. So it's up to you. But I do want to thank Cerise so much for her presentation. And now we're going to move on to our second presenter, who is coming to us from the West Coast. So there it is 7:45 in the morning. So Lisa, we really appreciate you being here so early and getting up extra early to be with us. As the Workforce Development Coordinator for the Washington Association for Community Health, Elisa Burgess works closely with community health centers across the state to find creative ways to recruit and retain a highly skilled and representative workforce. She also helps to manage the medical assistant apprenticeship program by coordinating new cohorts and communicating with healthcare employers so that more people have access to this unique healthcare career pathway. And she will be discussing effective strategies for the healthcare workforce pathway. And before she speaks, I wanted to let you know that every state in the nation has an association like the one that Elisa works for. Here in Pennsylvania, it's the Pennsylvania Association for Community Health Centers. So Elisa, I'm going to turn everything over to you. Thank you again for being with us.
Thank you, Lisa, and thanks to the organizations here for gathering and talking about really important work. She gave a great introduction about the organization that I work for, the Washington Association for Community Health. We are Washington State's primary care association, just as your Pennsylvania Primary Care Association exists. And I think we might even have some staff members here on the call today. But underneath our big primary care organization, we started to create healthcare apprenticeships. And we wanted an organization name to sort of fall underneath our big association name and host all of our healthcare apprenticeships. So that's where we created InReach, that second logo you see on the screen. That's the Institute for Rethinking Education and Careers in Healthcare. We established the very first healthcare apprenticeship program in Washington State with this medical assistant program back in 2014. So it has become extremely successful and also provided a model for other organizations to create different healthcare professions apprenticeship programs in our state. And just want to give you a little brief overview. You may not be familiar with apprenticeship in the healthcare world specifically. I know a lot of people think of plumbers, they think of electricians when you're thinking of apprenticeship, and our model follows the exact same idea. So we are managed by our state's Department of Labor and Industries. They manage all apprenticeships across our state, and they set these requirements. So actually for healthcare, they work with our Department of Health and the credentialing office to sort of determine how can we create an apprenticeship program that fulfills all of the required skill sets that DOH requires for every profession. So for medical assisting in Washington State is a certified position. You have to go through an educational program, usually at a community college level, in order to become certified. So for our apprenticeship program, they are required to do 2,000 on-the-job training hours. This is the most unique part about apprenticeship, is that the majority of their learning is hands-on. These hours are spent actually in clinics. They are full-time employees of these healthcare organizations, and they work full-time. So 2,000 hours equates to about 1 year full-time employment. That makes our program a 1-year program. From day one, they are in the clinic, hands-on with working with patients. So it's really unique in that sense. At the same time that they're working full-time in the clinic, they're also completing related supplemental instruction online. So that is their online coursework. It's about 240 hours. We host our curriculum ourselves. We built it ourselves, and it is hosted on the platform Canvas. It is completely self-paced. So our apprentices, since they are working 40 hours a week, they do not have to meet for a lecture or anything like that. They get to do their work on their own time, typically in evenings and on weekends. The time that they spend in clinic is never allowed to cross over with the time that they're doing their online work. So work is work and homework is at home. Another big portion of the program is that they're required to attend 3 skill lab days. This is really our time to be able to verify their skill practice. The idea is that they're learning every single skill in clinic and hands-on with the patients, but we need a way to verify that their learning is actually being done properly and by the book in those clinics. So we bring them together 3 times over the course of the year. We host these lab days always on Saturdays to try to avoid crossing over with any work time. They come together into like a regionally centered location. We have instructors on our staff as independent consultants, and they host these lab days. They're MACs themselves. They have education backgrounds as well, and they're the ones who also grade their online homework, but they run these lab days, and we send them to clinics with all of the materials necessary for the apprentices to come in and perform every single skill that we require they learn hands-on in front of their instructor. As soon as the instructor sees that they can perform those skills with mastery, she doesn't have to interrupt and, guide them to the right technique or setup. As long as they can do it on their own with mastery, they get signed off by our instructor, and that allows them to go back into the clinic after the lab day and actually perform those skills independently now in clinic. So until they go to those lab days, there is some visual supervision happening within their learning in clinic, but as soon as they're able to demonstrate mastery for our instructor, they get to do those skills independently right away. So to also give you some background about the program, we run the program based on a tuition kind of basis. So we charge the tuition directly to the healthcare employer. So like I had mentioned, my organization does represent all community health centers across the state. However, one of the requirements of being a state registered apprenticeship program is that you actually offer the program broadly to all employers in the state. So while our community health centers do use the program very regularly, we also have private healthcare institutions that use the program as well. So We charge this tuition to everybody. It covers things like the students' textbooks, our admin time, our instructor costs. It also covers their first attempt at their final exam to get licensed, and it covers enrolling them in a study course at the end of their Canvas learning as well. One unique thing is that they get to work at the top of the MAC license. So for us in Washington State, a medical assistant certified is the person who's able to do very invasive skills like phlebotomy, injections, cardiopulmonary procedures, even clinical procedures like suture removals, staple removals, things like that. So from day one, they can work at the top of their license. What this really allows for our employers is if they bring in an apprentice who already has some clinical experience, they get to start working, at their current level right away. There's no point where an experienced healthcare worker, maybe we see CNAs come into the program quite often. They can do a lot of these skills already, and so they're able to sort of jump in right at their current level and start working from there. But as often, we have apprentices join the program who have no healthcare experience at all, and they're equally as successful in the program, and they get to kind of walk it along at a little bit smaller baby steps. They do take the CCMA exam at the end of the program. This is the Certified Clinical Medical Assistant exam. It's a little bit different than the AAMA exam, which is another popular one. The AAMA is really more focused on anatomy, physiology, the more textbook, typical community college level education. But because our apprentices are spending the majority of their time hands-on in the clinical setting, the CCMA exam just matches up a little bit better to our program and our curriculum. It is a nationally recognized exam put on by NHA, which is the National Healthcare Association, and they do receive a national license once they pass this exam. The program is technically 12 months because you can gather 2,000 hours in 1 year. However, life happens for these apprentices. They are hardworking folks, but they have real lives too. So, we have someone every cohort who needs to go on maternity leave. People have to take FMLA to take care of their families. They maybe need to be off for a few weeks for certain travel. And we're very conscientious of that. So the average time we like to say is about 15 months for an apprentice to finish up and become fully licensed. So some of our employer requirements for any healthcare organization that's looking to become involved, they do have to pay the apprentices. So because we are a state registered apprenticeship program, the state gives us some wage requirements. We get to base our journey level wage off of our own employers though. So we take a wage and retention survey every year and we ask, what are you paying your starting MAs? We take the lowest of those reported wages and we make that our journey level wage. The state says that our apprentices have to make 92% of that wage for the first half of their program. Once they reach 1,000 hours or they're halfway through, they need to make at least 96% of that journey level wage. You can see those on the screen right now. That is for Washington State. But I'll tell you, if you're not familiar with the makeup of Washington State, Western Washington is very urban, going up and down the western side of the state, Seattle, Tacoma, that entire area. But as soon as you get into central and some of eastern Washington, it becomes very rural. So these wages, it's one of the reasons we set it based on the lowest. We want to make it fair across the board, and we want our rural healthcare offices to be able to participate in this program with equal success as our urban health centers in Seattle. So our wage spread between our apprentices is big. There are big wage differences between Seattle and say Moses Lake, Washington, and that's a very rural area. So to see these differences is good because they're all able to participate at their own level and at the level that their leadership staff is going to approve. I think that's always a big concern for employers is how am I going to get my leadership staff to sign off on this? Because not only are we having to pay somebody a full-time wage and benefit package, but we're having to pay tuition on top of it. And the lower wages allowed for the apprentices is a big benefit to some of those more rural employers. The state also requires that we have them give a one-on-one coach. So these coaches are current MACs themselves who have been working in that license for about 2 years or more. And they're assigned to each apprentice. And I think this coach-apprentice relationship is one of the best pieces of the program. The apprentices constantly are telling us the reason they stick around in their clinics is because they have this built-in support. And they really enjoy having that one person that they know that they can go to inside of the clinic. That seems to be very important to them. Of course, every employer has to ensure that their apprentices are going to get the adequate skill practice that they need. We have a complete skill list. And because the apprentices are receiving a national license, we have to make sure they have a very well-rounded education and that they could take their work anywhere else. So they have to learn every skill in the MAC scope of work. So if they are assigned to maybe a pediatric unit, some specialty unit, we do have major hospital systems that use the program as well, which they tend to place their apprentices into specialty units. We do ask that they rotate them into other jurisdictions so that they're getting that well-rounded education. They provide general support to their apprentices, and we always need a contact person at every employer who's sort of acting as the program coordinator for the logistics of the program. Some statistics I just wanted to show you guys if you're interested in our program. Like I said, it's been running since 2014. Currently, we have about 245 apprentices who are going through the program right now. We've graduated about 430 since 2014, and our last wage and retention survey showed that 86% of our apprentices are still working at the organization who put them through the program. For us in Washington State, that is a huge benefit for the program. Our health centers especially do not see that kind of retention rate for medical assistants. It's a pretty high turnover job for them. They struggle to keep them in because of the private employers who are paying medical assistants a lot more than the health centers are able to pay them. And then we have 27 health centers in Washington State, and 78% of those do participate in this program for us. And they participate over and over again. They are a big percentage of our overall apprentices, and we think that they see equal benefits as our big healthcare systems who might have more funding than the smaller, more rural clinics do. Here's a little demographic makeup of our apprentices. We have still majority female, but a pretty good spread on our age groups. We are happy with that. I like to put that one on here to show that it's a program meant to be flexible for anybody, that you could come in at any age, at any level, and be successful as a medical assistant. It's a great place to start a healthcare career, and it's a great place to come into it a little bit later in life as well. We are always working on our race and ethnicity spreads and hope to keep increasing those. If you don't know, Central Eastern Washington does have a very high Hispanic population. So our high numbers there we are happy with, and that is largely due to our rural and federally designated community health centers there in those areas of Washington. They're doing a really wonderful job of directly recruiting into their communities and bringing members in to start a career as a medical assistant. We also ask about prior education. We see a decent spread there. Our requirement for the program is that they have at least the GED level education. And then anything above and beyond that is just bonus for them. So we see all sorts of levels coming in to the program. I see a question here. If I could share a little bit more about how we recruit the clinics to participate, and I'd be happy to talk about that. We when we first created the program, we created it specifically for the community health centers. So we did a lot of outreach to them specifically, and they're the ones who said we need this program. We actually created it because Washington State required that MAs become licensed in 2014. So our health centers needed a way to get their staff licensed without losing them to have to go back to school. The apprenticeship was the answer to that. So at the beginning, a lot of our health centers jumped on board simply for that reason. And then they began to see the benefits of the program and continued coming back. Now, when we're reaching out to new organizations or even some of those health centers who haven't participated yet, a big turning point, of course, is that retention rate that we're seeing. We have seen that across the years. I have another slide about benefits to everybody. I mean, you can kind of understand some of the benefits both to the apprentices and to the health centers. For our rural health centers, the biggest part, a lot of them do not have community colleges nearby where their community members can go and actually get an education for medical assisting. And so they were struggling. They had no way of recruiting people. They're leaving their area to go to community college far away and get their education there, and then being hired into healthcare organizations right around that same area. So being able to offer a program where they don't have to leave the community and they can stay right where they're at and just start working was a huge point for those employers. Maybe my next slide, perfect. Some of the other benefits there is that they get to grow their own. We have about a 60-40 spread between 60% incumbent employees using the program and 40% being new hires to the organizations. So we definitely encourage that they're using the grow your own model, reach out to their current employees. We see janitorial staff, we see cafeteria staff, we see CNAs, medical records, medical billing and coding, even radiology techs. For us, we have a position that's medical assistant registered, and that's just a little bit lower level of a MA. We see all of these different positions coming into the program as incumbent staff. So we highly encourage them to reach out to their current workers and offer this as a career growth opportunity within the organization. We also see a benefit with clinic flow and retraining. They're learning their skills in that specific clinic setting. They're not having to retrain them and say, oh, well, this is how we do it here. Here's how our clinic flow is going. Here's our EHR system. They already know it. And as soon as they get licensed, they're able to be placed with a provider, and there's no extra training that needs to happen. They actually learn the job specifically for that employer. Also the cost. I had mentioned how the wages requirements are a lot lower. I have heard from some of our community health centers in the rural areas of Washington that they have to pay freshly graduated MAs out of a community college program close to $20 an hour. For our apprentices, you saw those wages, they're far lower, and we do encourage them as soon as they graduate. A lot of organizations still give them a little bit of a raise, but it is nowhere near the wage that they have to offer to get the community college graduates into their clinics. So they're just a lot cheaper of an option for the health centers. We also offer a trial period per se for the tuition. They're always worried about that tuition that they're paying. So if an apprentice drops out within the first 2 weeks, we do offer a full refund on that tuition. And then if they drop out past 2 weeks, but up until 10 weeks, we offer 67% refund on their tuition as well. A lot of our organizations also require commitment contracts to be signed. That's totally up to them and allowable. So usually it's a 1 to 2 year commitment contract being signed. And if the apprentice leaves after they graduate, they do have to pay back some prorated amount of that tuition. And it's a really flexible position. While within the 1 year apprenticeship program, we do require that they're learning the entire MAC scope of work and that they are being rotated here and there. Once they finish, employers can use MAs in so many different ways. And I think that has become really apparent, especially after COVID. We had apprentices and MAs being used as greeters and screeners for people coming into the clinic. They're out there in the COVID vaccine clinics. They're doing the drive-through work. They're being used in so many different ways. So it is a nice position to focus on because of the really large scope of work that they can do. Specifically for the apprentice too, it's a very competitive program at many of our organizations. I just talked to one provider yesterday who they had 15 spots to fill for a cohort. They had 50 applicants and they're interviewing 30, so they have to whittle it down to 15. That is in Spokane. Some of our Seattle-based organizations have upwards of 300 people applying for 12 spots. So it tends to be quite competitive in our higher populated areas. They get to remain local. That's always huge, especially for our rural community health centers. They get to come out with no debt because the employer is paying the tuition. They're not paying anything to be a part of this program. They're actually being paid to be a part of the program. Again, they're a full-time employee. They get to have a benefits package. They get to provide for their families at home while they're furthering their own education. They also get to learn hands-on. That's a huge thing for a lot of people. Not everybody is suited for the community college sort of track of learning out of the textbook, listening to lecture. That's not everybody's best learning model. So for people who truly do learn best hands-on, we see them succeed with flying colors in this program because that's truly the basis of it all. And they're also a valued care team member. So when, like I said, when we reach out to those who are still working for their organizations years and years after they finish the program, why are you still here? It's because they feel like a valued care team member. They know that their employer was willing to make an investment in them. They believe that they could be successful, and they give back to their own communities because for a lot of them, they were able to stay in their own communities. That's huge. So for them, that has always been the biggest feedback that we receive from those guys. That's just a little bit about our program. I do have my email there if anybody would like to follow up and ask any other questions. I'm happy to always talk about it. We do offer consultation options for organizations outside of our state as well. So I'm always happy to talk more about it with anyone. And it is a model that I think can be adapted and put into any state. We do have some states that are using our curriculum actually right now to kind of start their own projects and things like that. So it's definitely doable. Let's see. Can you comment on how access to community college and training centers impacts the program? Yeah, so for us, we didn't start out making connections with our community colleges and training centers. However, since the program has sort of really evolved, we do have community college partners now. We partner with them in ways they review our curriculum on a regular basis to make sure that sort of our curriculum still aligns with the general state curriculum that the colleges are giving. We also provide, in the past, we had provided some credit hours for our apprentices. That's not something we're currently doing, but it is also a possibility, I think, if you're looking to recreate a program like this. And community colleges are such a great partner to have and to be able to use their curriculum if you want. Not many programs are interested in building their own curriculum. Quite frankly, it takes a long time and it's very expensive. And so if you do have a community college nearby who has curriculum already built, they're the best people to reach out to and see if they're willing to partner with you on a project like this. And the training center. So actually a new project that we're sort of just starting to get our hands in is looking at pre-apprenticeship. We have a lot of training and skill centers across the state of Washington who work directly with our high schools. And there are medical assistant high school programs running all across our state that we have not partnered with yet. And so we're now starting to have those conversations to look at how can we partner and have them create pre-apprenticeship programs where they would funnel high school students directly into our apprenticeship program. We have one organization that does this currently in a more informal way than pre-apprenticeship, but they partner with their local high school and their local training and skill center, and the students, usually seniors in high school, complete a one-year medical assistant class as a part of their high school curriculum, and then they get to move directly into our program. They go through the complete application and screening process as any other employee. So they're getting all of that experience. But to be 18 years old, fresh out of high school, and have a career almost guaranteed for you there in the healthcare system is pretty unique and amazing. And so those training and skill centers are huge partners to be able to broaden our scope and create those direct pipelines for the positions, especially like medical assistants that are hard to recruit and hard to retain mostly. Yeah. Thank you guys so much for having me.
Alyssa, thank you so very much for your presentation. If you're this good at 7:30 in the morning, I imagine you're great after 8 a.m. So thank you so much, and very much appreciate the questions that we got and the ability to be able to replicate what you're doing in Washington State here in Pennsylvania. It looks like we do have some interest potentially from UPMC, and I'm sure others as well. So now I would be very happy to introduce Micah Gorski. Micah is he's at the St. Luke's University Health Network Miners Campus, where he is the Rural Health Clinic Administrator and the Director of Business Development and Physician Relations at the 49-bed hospital located in beautiful rural Coaldale, Pennsylvania, which is a Medicare 4-star hospital. The St. Luke's Rural Health Clinics are the site of Pennsylvania's first family medicine rural residency training track, and they will begin a rural psychiatry residency in the very near future. They were named Pennsylvania's 2016 Rural Health Program of the Year and the 2018 Outstanding Rural Health Organization by the National Association of Rural Health. Micah will be discussing the successful strategies that St. Luke's has implemented to attract and retain providers. So Micah, we'll turn things over to you. Thank you so much.
Thank you. And I want to thank you for inviting me and thank the bank for hosting this event and bringing this group together, not only the panelists, but the participants. I've enjoyed, Cerise, your presentation, and Alyssa, your presentation. You should be really proud of the work that you're doing. Alyssa, I love that you're focused, built the program around incumbent workers. That you know, a lot of times when we recruit and we retain, we often focus on the new people, and it's really important that we don't always do that in an unfair way. So, Lisa, thank you for moderating. My name is Micah Gursky, as she said. I work at the St. Luke's Miners Campus. That's miners with an E, not an O. We're a coal miner hospital. We are not a pediatric hospital. And I'm going to ask Sean to advance my slides. And Sean, you know, if you could just advance to the next slide, I'd appreciate that. We are a small rural hospital. Those are coal hills in the back in small Coaldale, Pennsylvania, in northeastern Pennsylvania. We were built by the hospital, by the miners back in 1910, and continue to be a small rural hospital. Sean, if you could advance, I'd appreciate it. I've been with St. Luke's Miners Campus for 14 years. And just a couple of weeks ago, we were named by IBM Watson and Fortune as a top 100 small hospital in the country. Really proud of that. We're actually number 14, which is really remarkable because, you know, the trends will tell you that small hospitals shouldn't exist in Coaldale, Pennsylvania anymore. And we're not only here, but we're financially strong and providing really, really good quality. So very proud of my colleagues that helped to make that happen. And I'd like to talk a little bit about some recruitment strategies and things that we've used that have worked. Honestly, I don't know if they would work in your setting or not. You know, these were designed to work in our setting and recruit and retain talent here for our hospital. But I bring up the top 100 hospital not just to brag, but also, you know, I think that our recruitment and retention strategy is really part of the reason we don't do it because we're a top hospital. We're a top hospital because we do it. We really believe in bringing on the best people, even in a difficult and tight rural healthcare market. Thank you, Sean. If you could advance to the next slide. We are part of a top 15 health system in the country. IBM Watson named the St. Luke's University Health Network one of the top 15 networks. We're also a top teaching hospital in our network. So we have the advantage of being part of a very, very strong and healthy health network that prioritizes its rural campuses as well. So we're in northeastern Pennsylvania. We have 11 hospitals, one in New Jersey and the others in Pennsylvania. So just to kind of give you an orientation, our little hospital is the one that's right on the Schuylkill County, Carbon County line. And we're now going to be bordered by 2 brand new hospitals. And so we're performing well, even though we compete not only with other hospitals, but also with our own health system. Thank you, Sean. If you can move ahead. This kind of gives you an idea of, you can see the concentration of services that are in our urban areas, the Allentown, Bethlehem, and Easton area. And then you can see that in the Carbon and Schuylkill area, sort of where we're more remote and rural. And that's where our rural health clinics are located. So the community health centers that Alyssa was talking about, we use that model to provide care in rural underserved areas. Underserved meaning not a lot of providers for the number of patients. Thank you, Sean. Move ahead. Thank you. As our small hospital, we have a 13% turnover rate. The national average is 19%. For you non-healthcare folks on the webinar today, healthcare has an extremely high turnover rate in terms of employees. It's a very competitive market. There's a lot of options for talented healthcare workers, and people often are on a career path and a career ladder that leads them to other organizations and to other areas that impact our turnover rate. But we do have a pretty good turnover rate compared to the national average. Thank you. Sean, if you can go to the next slide. And for those of you who are in the health system, you might know about Qualtrics and employee engagement scores. We do survey our employees to see if we're a good place to work. And we have we're a very high performing hospital when it comes to how our employees enjoy working here. We measure this with an employee engagement survey that is benchmarked against national averages, and we're consistently in the 89th to 90th, 92nd percentile ranking, which is really remarkable for a small rural hospital. We're very proud of that. We like working. Our people like working here. Thank you, Sean. And we really, because we're a small rural hospital, we really believe in being integrated in the community and getting out there and talking to people, not just about recruitment, but about our health systems in general. And really, we're the largest institution in our community, so we have an obligation to live that role as well. This is a clip where we go out and we help students with interviewing skills. And do career fairs to talk not just about our jobs, but also some of the things that it will take for our local students to compete well in the workforce, whether they're interested in healthcare or not. Okay, Sean, thank you. And when we go out into the community, we do a lot of literacy promotion, because literacy is tied to health outcomes. When we go out into the community and we talk to our students at these health fairs and things like that, I'm paraphrasing, but basically the students say, I want to work really hard. I want to get good grades because I want to leave this area. That is their MO. That's what they're taught by sometimes their teachers and their guidance counselors and their coaches and their parents and their neighbors and their friends. And it really is a place that's thought of as a place where you're supposed to grow up and leave, work really hard and get out. And so, when we get into the school and talk about that, that's the prevailing attitude, and not just from our students. This is not an accident that the students often have this approach. We teach it to them, and the people who are closest to them and they trust the most often help them to convey that. So our strategies are really designed to mitigate that. Sean, if you could advance the slide. One of the strategies that we use, well, of course, is the traditional hospital and healthcare advertising, big billboards, and we do a nice, our marketing department does a really nice job of trying to attract people when they're ready for employment or they're already employed in the workforce. This is both a postcard and was also a big billboard that we used. Okay, if you could advance, Sean. So we do the traditional things like grow your career with us, recruiting doctors when they come out of their residency or fellowship program, offering them incentives. And Alyssa, I really like the conversation that you were having about the wages that we pay in rural areas compared to urban areas. And I often talk to our recruitment team about, the fact that sometimes there's this false impression that we need to pay people in a rural area less. And I always push back by saying, how much of a pay cut would you be willing to take to work in Coaldale, Pennsylvania? We have to incentivize. We actually have to pay more sometimes to recruit our talented physicians, particularly nurses, doctors, to live in our area. This idea that somehow the cost of living is somehow going to compensate for your wages. Well, that doesn't translate when you go to retire, and your retirement is based on your lifelong earnings. So we've really worked with St. Luke's to incentivize people to work in rural areas. Okay, Sean, if you can move to the next slide. And of course, we use some of the tools of the trade that a lot of our counterparts use, the other community health centers, FQHCs, and rural health clinics, using the National Service Corps program, loan forgiveness programs that are available, and things like that. Those are pretty standard industry things now, but really should be engaged with those. But I'd really like to talk about some of the other programs that we use. But these are the things that we use when people are ready to enter the workforce. Go ahead, Sean, if you can move to the next slide. And one of those strategies is developing talent. As Steve mentioned earlier, creating a residency program that's specifically designed for family medicine physicians who want to participate in a rural practice, want to practice in a rural area, because their physicians are very likely to work where they do their residency program. So we did start the first rural residency training track in Pennsylvania for family medicine. We're graduating our first class this year. And we really get them involved in the community. We're expanding, we're actually doubling the size. Don't get too excited. We're going from 2 in a class to 4 in a class. So we'll go from a 6 physician program to an 8 physician program. But to try to get those, not just when they're ready to go into the workforce, but try to get involved with recruiting them while they're doing their training. And you'll see as we go through the strategy, how we're doing that, not just at the residency program, but with some other levels of training. Next slide, please. We also do this with nursing. Nursing is a tough recruit. Actually, PCAs and nurses' aides are a tough recruit these days too. But we do it with a nurse residency program as well. So not just looking for nurses who are already working, but also looking for and when they're in the workforce, but also doing education programs, including a nurse residency program, and really focusing that in our rural hospital. Next slide, please. The part of our family medicine residency program, we actually take our rural physicians fishing. This is Jack Quetter in the middle. He's a hospital board member. These are 2 of our family medicine residents. Neither one had ever been fishing before. And so we said, if you're going to be practicing in a rural area, particularly our rural area, you need to know how to fish. So we take them on a fishing trip every year. So next slide, please. And then the residency program is part of our larger network strategy. We have a large residency offering, not just family medicine, not just rural family medicine, but really trying to get to those physicians when they're choosing their career path and their education path, not just when they're picking which job offer they're looking at. Next slide, please. So several years ago, about 10 years ago, we started our own medical school. So to go back behind the residency, now you're in the career path of medical school, because often physicians practice where they're trained in medical school as well. They choose their residency program often based on where they do their medical school training. So we started our own medical school, the Temple St. Luke School of Medicine. It's based in Bethlehem, where our main campus is. So we start recruiting very early. Next slide. We also have some scholarship programs that are specifically for our rural areas. We have an endowed scholarship that will provide funding for local rural students who want to attend our medical school. So this is Matt Zuber on the right here, who was part of our inaugural class from my hometown of Tamaqua, was part of our first class in our medical school. So we recruit them, local students, and try to help those local students. Next slide, please. And of course, we also do the same type of thing with our advanced practitioners. This is Ken Cherry, who was the preceptor of the year for precepting physician assistants. So when we're recruiting those advanced practitioners, investing in those people who are interacting with them during those mentorships, during those apprenticeships, during those precepting experiences is really important, because they can do a great job of precepting, but not recruiting. So you want to make sure that you're investing in those people who are working with those students on a daily basis. Next slide, please. And we do a lot of job shadowing opportunities, mentorship opportunities, bringing people into the OR to scrub in and observe, whether they're students in high school or college, to help them during their college experience, to help them make a good career path. Next slide, please. Of course, St. Luke's has the nation's oldest continuously operating nursing school. So in addition to our medical school, we also train a lot of nurses, and we hire a lot of nurses right out of our own medical school. And next slide, please. It's also wonderful that St. Luke's University Health Network offers free tuition for any employee of St. Luke's who wants to go to our nursing school. So if you work in the cafeteria, you want to go to nursing school, we'll pay for it as a way to help you on your career path, but also help us get some nurses. And then we do some unique things. We do what we call a Future Physicians Dinner. We're going to be doing it outside this year. We did it virtually last year. This was an idea of Matt Zuber, who we had showed a picture of him. He was in our first medical school class. But when he was in high school, he didn't know any doctors. The only time he ever saw a doctor was when he was in the exam room. He didn't really have an opportunity to interact with that profession. And I said, well, what would you do to change that? And he said, well, can't you just I don't know, invite your doctors to dinner and invite some students to dinner and have them just have dinner and talk to each other? And I said, well, yeah, I think we can do that. So we've been doing this since 2009. And we literally just buy dinner and get out of the way. There's no speeches, there's no programs, and they talk on a level playing field as students and local physicians. And we knew this was going to be powerful and impactful for the students to hear about the experiences from the doctors. One of the pleasant surprises was hearing a physician explain to an 18-year-old how they came to practice medicine in Coaldale, Pennsylvania. I don't know if they were surprised by that question, but it was really, really wonderful to hear the physicians articulate why they chose a rural setting and why they chose to practice where they're doing. And we've been recruiting, so we recruit high school juniors and seniors to this program. Next slide, please. And they come and they just have dinner with our physicians, and they talk about career paths and training. And we've recruited right out of here. This is Matt Zuber. We recruited him to our medical school. And he's now actually in a Gyn-Onc fellowship program. Next slide, please. But we've also recruited other students. We have, next slide. I think we had this one already. We actually recruited one of our students to our residency program. Next slide. His name is Dr. Dan Plavin. Next slide. These are pictures from our Future Physician Dinner. Next slide. Yep, and we did it virtually last year. This year we're going to do it outside, but last year we did it virtually. And our physicians, it really gives them a sense of purpose when they're mentoring younger students. Next slide, please. This is Dan Plavin. It's a picture of him when he was in high school, and now on the picture on the right is a picture of him. He's a second-year resident in our rural family medicine training track. So we literally started recruiting him out of high school. Next slide, please. And we really think it's really important that we do start early. We mentioned the residency program. I don't know why this slide is duplicated. I apologize. Next slide, please. We also provide scholarships, and we used to do a scholarship program where we would bring students in. This is a student that we provided a $1,000 scholarship to, and she became a nurse. She's working for another health system. But we used to just ask guidance counselors for people who were interested in healthcare, invite them to a photo op, hand them a $1,000 check, and then a lot of times we never heard from them again. Next slide. And so although we did help them, and we helped a lot of students, next slide, we really didn't develop the relationship. So about a year or so ago, or 2 years ago, we started a new program called the Mentorship Scholarship Program, where now the scholarship is tied to developing a formal mentorship program with one of our leaders. And so you spend a year in a mentorship program with the leader, and there's certain things that you have to do during that mentorship program. Next slide. To get your scholarship. So you not only get a check, but you get a contact, somebody who's on the inside. You get to know somebody. You get job shadow opportunities, and you get somebody who can help you on your career path and your education path. Next slide, please. And as good as it has been for the students, it's been wonderful this is our hospital president, Wendy Lazo, with one of the mentors and their students. It's been really good for our mentors as well, because this provides value to them beyond just punching a clock and doing their job on a regular basis. They know that they're helping build a future for the hospital too by impacting these students. Next slide, please. And I know I'm running a little bit late, Lisa, so I'm going to run a little bit late. So this is some more pictures of some mentors and their students. They really get engaged, and it lights up our staff, not just the students. So we found it a benefit for not only the students, but the staff. Next slide, please. So when you harken back to those engagement scores, those employee engagement scores, this is what engages our teams when nurses can mentor another nurse, and we actually let them hand the check out instead of having our board of trustees or hospital president hand the check out. They got the check from their mentor. Next slide, please. We also do a middle school STEM program where we invite students in to do some STEM activities. Next slide. These are 6th, 7th, and 8th graders. When we talk with our dental team as well, and just teach them about not only health but health careers and the importance of science and their studies in their career path. Next slide, please. And so you can see the wonder on their faces during the STEM activities. Next slide, please. This one's my favorite. Really engaging students at a very young age and helping them understand that these are exciting careers that we have here at St. Luke's. Next slide, please. And we also go into the elementary schools and we read to students, talk about the importance of literacy, talk about the importance of doing well in school. We have our doctors go in and spend time and sit on the rocking chair, sit on the floor and read to students. And our residents, we do that as well. And just start to build those relationships with those students and teachers and schools very early, because we're the big institution in the community, so we have that obligation to do that. It's good community health, but it's also good recruitment. Next slide, please. So you might say, Mike, would you go all the way back into the womb and recruit people in your community? And I think that would be a little too far, but this is a picture of Abigail Rakos. She was spent first 4 weeks of her life in our neonatal intensive care unit in Bethlehem. Next slide. She grew up wanting to be a nurse, and we knew that, and we started recruiting her very early. When she graduated from high school, we offered her a general education scholarship, and then we also promised her that if she went to our nursing school, we'd pay for that too, if she wanted to come back and work for us. And so we presented her with this opportunity. She finished her gen eds, went to our nursing school, graduated recently, and we just hired her. So although we don't go all the way back to the womb, we do go back to the neonatal intensive care unit to start recruiting some of our providers, our nurses, and our professionals. And so Abby's a great story about how, when you have a long-term vision and you're in your play space, you can afford to spend some time. I had one person say, Micah, don't you think it's a little early to start recruiting doctors when they're juniors in high school or sophomores in high school? And I said, are you telling me in 14 or 15 years we're not going to need doctors? No, it's not too early. And so now we're seeing the fruits of that work that we've been doing for a long time. Next slide, please. And so this is her graduating from our nursing school, and we offered her the job, and she's doing great. She's doing a great job now. Next slide. So that's my story about St. Luke's Miners at Lowell Hospital in Coaldale, trying to keep that pipeline full for professionals coming, in the coming generations. So thank you.
Micah, thank you so much. I think it's pretty obvious that Micah's just a little bit enthusiastic about the work that St. Luke's is doing, and certainly has been a rural health advocate across the state. And he is a perfect example of someone who grew up in the community in which he lives now, went away to college, and then came back and has been an integral part of the work that he is doing. At this point, we are a little bit over in time. We probably have time for a question or two if there's anything that anyone would like to ask. I don't see anything in the chat box. At this point, we've had some great questions though, and also some nice responses in terms of the importance of the presentations. So again, I so appreciated the opportunity to to be the moderator for this session. Nathaniel, thanks again for asking me to be part of this. And at this point, I think I'm going to, we do have a question. Micah, could you say a little bit more about your collaboration with Temple Medical School?
Sure. So St. Luke's, in our effort to establish a really robust and start to finish education services for health professionals, we had a long history with our nursing school, and we wanted to start our own medical school. If you've ever started a medical school, it can be very challenging, and so we found a very good partner with Temple University. And so when we started the program, the first year of medical school, the first year students would spend that year at Temple's in Temple's program in Philadelphia, and then the second, third, and fourth year they would spend at the Temple St. Luke's School in Bethlehem. And so we started that intentionally. It's a small program. We have about 33 students in a class, but intentionally to provide a local opportunity for medical school, but then also to introduce physicians very early on in their education career to what St. Luke's has to offer. And so it was something that we could not have done on our own to get it started. And so partnering with Temple was a really smart way for us to do it, and we really appreciate the partnership with Temple. And now that we've been doing it for a while, we feel a little bit more comfortable. And first year students, will be supposed to be spending their first year at our Bethlehem campus. So I'm not sure if that answers your question, or if you have a specific question about the program or about the scholarship programs that we offer. But it's really an opportunity for us to train medical students in our University Health Network system, and it's both good education, but it's also good recruitment.
And Micah, there was a follow-up question. Does Temple help you recruit into your rural employment pipeline?
No, actually, most people never heard of Coaldale. So it's we have a pretty good relationship. I'm not saying we don't expect them to. I mean, they're recruiting for a lot of underserved areas in the communities that they serve. We interact with the medical school. We'll often have our residency team go and speak to our medical school class. We'll have medical students who are interested in rural come here. But it's really more driven by us, sort of inserting ourselves into their process, more so than a concerted effort by our medical school to push out into the rural areas. So we're sort of banging on the door saying, can we talk to the medical students? Because maybe 1 out of 33 might be interested in rural, but our chances of recruiting that 1 out of our own medical school is a lot higher than somebody in some other program.
And one final question for you. How does St. Luke's decide which students to invite to the dinner with the doc?
That's a great question. So what we do is we ask our guidance counselors to identify 2 or 3 students from 5 local high schools. And so that's the primary way that we get invitations. But then we also use our network of employees and community partners. So if somebody knows somebody who's interested in becoming a physician or thinks they want to become a physician, if they suggest a name to us, we'll just invite them to the dinner. That Future Physicians dinner was Dr. Zuber's idea, and it's really elegant because it's so simple. And for you hospital administrators out there, it's really inexpensive. The physicians come and they donate their time. We buy dinner, and we just develop those relationships. So we'll take any students that are suggested to us from the region, and we also often invite college students or even medical students who are interested in meeting some of our physicians. It's primarily focused on high school students, but we do have college students and med students attend as well.
So thank you. And again, a collective clap for everybody, or from everyone, to all of our presenters. So thank you again for your time. I'm going to turn things over to Nathaniel now, who will lead us into our break and then tell you a little bit about the breakout sessions that will take place.
Thank you so much, Lisa, and to Cerise, Alyssa, and Micah as well. Those informative presentations will really help to guide our conversations in the breakout discussions. So everyone, please do stick around and participate in the breakout discussions. Your feedback and input is really important, and we're eager to continue to engage with you all in this space. However, we all are going to take a much deserved break. We'll come back at, say, 11:42 to give you a 5-minute break. So I will break everyone out automatically into those sessions. I believe I have everyone assigned, but I will ask you directly in the chat if I have not assigned you to a group yet. These discussions will not be recorded, though we will be taking notes on them for informing additional programming and engagement around these issues. And then it looks like we'll reconvene at about 12:10 or 12:15 and try to report back. We're going to ask one person from each of the breakout groups to report back to the full assembly about what their conversation focused on. So again, thank you for being here, and we'll see you in 5 minutes in the breakout groups. All right, welcome back, everyone. I hope everyone enjoyed the breakout groups. I'm looking forward to learning more about what was discussed. So we'll now ask one volunteer from each group to report a summary of their group's discussion. Each volunteer will have roughly 3 minutes, so please try to summarize it quickly and succinctly. We want to be mindful of everyone's time. So who from the apprenticeships breakout group number 1 has volunteered? If you could please unmute yourself and state your name and organization before sharing your summary.
Hi, Nathaniel, that would be me. Christine Caldera Piatos. I'm with the Center for Rural Pennsylvania. And in our working group, we talked, it was the apprenticeship model number 1. We talked about Alyssa's presentation on apprenticeships out in Washington State. Folks were interested in learning more about that model. Jason from Penn College of Tech talked about his EMT hybrid model that they are going to be instituting, and it's the EMT pre-apprenticeship model that they have instituted already, and a paramedic apprenticeship model that they would hope to introduce soon. We talked about, Alyssa mentioned in Washington, they might be looking at a behavioral health apprenticeship model. And the folks in our group thought that was a great idea too, just because of fewer folks going into behavioral health as an occupation. We looked at opportunities that already exist. And Lucienne had mentioned in the Poconos, especially during COVID, the hospitality and retail services industry kind of took a hit with employees, and the employment fell off. And perhaps how to look at ways for folks who are unemployed in those industries, looking at their skills and level sets and how they might match up with some other job opportunities in healthcare, et cetera. We also talked about, and this was Sandy from Penn College of Tech. She talked about being a school nurse in Sullivan County. Sullivan County does not have a hospital or any emergency room services. She used to be a school nurse, and she talked about how school nurses were often called upon sometimes to kind of be the ER person in the area. And wouldn't it be a great idea to have some school-based health clinics in rural schools, especially because these rural schools might have more space now with population decline, not as many students. It might be a good opportunity to have some of these clinics in rural areas, in places that already have space for those types of clinics. Our group also talked about, Erica mentioned declining populations and how to address, where do we find people to work, and those are some issues that rural areas, I think, are going to be continuing to have in the future, as well as broadband access. That was another big one that came about, and how broadband access is critical to health and safety issues and every other issue as well. So just bringing broadband out to rural areas is very important. So I hope I captured everything that everyone said just in a real quick nutshell, and thanks everyone.
Thank you. Yeah, that was a great summary. And it sounds like you touched on a lot of really important opportunities, challenges, and resources needed for rural revitalization broadly. But thank you. I greatly appreciate it. So who from apprenticeship group number 2 has volunteered? Please unmute yourself and state your name and organization.
Hi, my name is Chantal Gerardo, and I am with the Philly Fed, like many of us here. For the apprenticeship group number 2, I'll really echo a lot of the comments that Christine talked about. So similarly, everybody was really pleased to hear that there's such a great apprenticeship model that could be replicated here. Ideally, it would be great to replicate that for a certified nursing assistant program. As far as barriers to access and opportunities, we really talked about how it would be extremely beneficial to have better public transportation access to get people to these training programs, how cost could be a barrier just because some of the short-term training programs aren't covered by Pell Grants. And then also, like Christine, we talked a lot about broadband access. So it's kind of a double-edged sword, because if these programs are provided virtually, which we saw a huge increase of during COVID, potentially some residents who don't have great broadband access wouldn't be able to attend those programs. But then on the other hand, if they have to get to these programs in person, it might be difficult to drive there without public transportation access. So one of the biggest things that we closed on is if there could be some type of investment in infrastructure in these rural areas to get that access, perhaps that would come through governmental assistance initially, and then private companies could take it over later on. That would be a huge win for the communities. So I'll turn it back to you, Nathaniel.
Thank you so much, Chantel. Yeah, and that, again, hitting on really important topics, broadband and transportation were both things that I know Steve mentioned in his opening remarks and that often come up. Infrastructure funding is really important, and we hear that pretty frequently. Now we'll transition to who from the community health worker group volunteered. Can you please unmute yourself and state your name and organization?
So we broke the rules a little bit, and I'm going to invite Cerise to start, and then Ted is going to offer her final comment for our group.
Great.
Sorry, you have to hear from me again. We had a great discussion. We had a community health worker in our room who was, sort of suggesting we open our minds to thinking about like where else community health workers could be employed. So like maybe just at like a corporate or private employer to support employees either with health goals or career goals. So we talked a little bit about those horizons, which was exciting. We also talked about broadband access and started to think about what's the framework we're using to think about, sort of the policy approach to rural workforce development. So I guess I am going to pass it over to Ted if I could, because he was very eloquently sort of stating both our problem and a direction for us.
Thanks, Cerise.
Yeah.
Thanks, Cerise. I'm not sure I was eloquent or stated direction. I may have confused things. But one of the issues that we discussed was that the issue of workforce, rural healthcare workforce, is not just a workforce issue. It's really a community and regional development issue, if you want to think about it that way. Both broader development as well as workforce development in the healthcare sector are vehicles for each other. And one of the things that's critical for fostering rural healthcare workforce development is ensuring that there is a broader community and regional ecosystem that supports the development of viable workforce initiatives that pay off at the community and at the regional level. Broadband is part of that. Transportation is part of that. Quality of life is communities that attract people are part of that. And so we talked about what some of us call this broader ecosystem to support workforce, employment, and development in communities and regions more broadly.
That's great. Thank you, Ted. I appreciate that. And that, I think, segues really nicely to our next group, the recruitment group. I think a really key component for in-migration to rural communities, population growth, and recruiting and retaining folks there is, like you said, Ted, regional strategies and these kind of reinforcing and overlapping issues such as transportation, broadband, et cetera. So who from the recruitment group has volunteered? Please unmute yourself and state your name and organization.
Yeah, hi, this is Judd Mellinger-Blauk, Director of the Pennsylvania Primary Care Career Center, and I volunteered to report to this. Our leader was Lisa Davis, and she did stop talking for a second to let some of us speak. So I'll be giving the briefing here. So yes, some of the ideas we had, I think a lot of what we're talking about is in recruitment is based a lot upon relationships. And we talked with, Micah was actually in our group, and we talked a bit about what Micah talked about with all the work they're doing on a local level. And so much of that is relationships, relationship building at an early age at, junior high, middle school, senior high, certainly senior high levels. He talked a bit about how they got physicians involved and how we talked a bit about how you get that buy-in. Bethany from Wayne Memorial was asking about getting that buy-in from the physician. So there you have relationships both with the physicians and with your future candidates, your prospects. We talked about getting those relationships out into the communities where you're getting the whole community involved in recruiting and retention. That's the big one. So it's, you can certainly recruit and dangle some nice benefits and a signing bonus and so forth to get somebody to come out into your community. That's difficult, but you can do it. But then how do you retain them? How do you get the entire community involved? And Bethany said she recruits, I wrote down her quote, she recruits the family more than she recruits the physician or whatever professional, because if, the old saying goes, now this doesn't apply to a lot of to female physicians all the time, but if mama ain't happy, ain't nobody happy. So you've got to make sure that the spouse is happy and that they're willing to stay. So yeah, that was a lot of it. We also talked about the need for, mentoring goes with it too, the need for mentorship. And that goes, and we also talked a bit about at least Bethany also mentioned a program where they encourage mentorship at all kinds of levels. So a brand new employee at an entry level or a frontline job would also be, they'd encourage other people in those jobs to mentor that person. It's not just a physician mentoring a resident or a medical student. It's a medical assistant mentoring another medical assistant or a community health worker doing the same. So I think that was, we didn't talk much at all about the old sourcing and advertising, and that's that kind of stuff that we all have to do to recruit and to get candidates in the door and resumes and curriculum vitae and that kind of thing, because that's kind of standard. What are we doing beyond that? What are we doing in addition to the traditional stuff? And I don't know if Lisa or anybody else wants to add anything, but I think that's what I had.
Judd, thank you so much. Those are really helpful remarks. And Lisa, did you have anything to add to that?
No, Judd is always is the perfect speaker.
Well, thank you again, and thank you to all of our panelists, our moderators, and especially our partners. I, in particular, want to thank our partners at Penn State Center for Economic and Community Development and the Center for Rural Pennsylvania. Please don't forget to take the evaluation survey, which will be copied and pasted into the chat in just a moment. And also save the dates for the next assemblies. We're going to have an assembly on community capital for rural revitalization on June 30th, and then another on entrepreneurial ecosystems, tourism, and seasonality on July 15th.